Tako, pozdravljeni na strokovnem posvetu z naslovom The Value-Based Healthcare Paradigm, From Concept to Practice. Na dogodku bodo slovenski in tuji strokovnjaki predstavili izzive in predlagali rešitve pri odločanju o najsodobnejših načinih zdravljenja, o inovacijah v javno financiranje in metodah plačevanja izvajalcev. Glede na ambicije, da v Sloveniji uvedemo protonsko terapijo za zdravljenje raka, bo v vsebinskem delu poseben fokus na onkologiji in na uvedbi konceptov na področju obsevalnih terapij za zdravljenje raka. Dogodek bo potekal v slovenskem in angleškem jeziku, brez prevajanja, in vas vabim, da vaša vprašanja posredujete v pogovoru v chatu. Na njih bodo gostje odgovarjali ob zaključku posveta. Glede na tuje strokovnjake bo koristno, če vaše vprašanje napišete kar v angleškem jeziku. V tej točki bi vas obvestil še, da se dogodek snema in bo tudi na voljo na našem YouTube kanalu. Jaz sem Miha Jurečič in sem del ekipe Ekonomske fakultete in moderator današnjega dogodka, ki je organiziran sicer pod okriljem Ekonomske fakultete v Ljubljani in ob sodelovanju ZZZS-ja in Onkološkega inštituta Ljubljane. Dear guests, welcome to our discussion where we will be talking about the value in value-based healthcare, the role of this paradigm shift in healthcare decision-making and its implications for proton therapy in oncology. This event will be held in both English and Slovenian language, although no translation will be provided. So if you have any questions for our speakers, please post them in the chat on Zoom, and we will address them at the end of the event. I would also like to inform you that this event is being recorded, and the recording will be posted on our YouTube channel. Besedo pa predajam doktorici Petri Dušinović-Bolča za uvodni nagovor. Petra, izvoli.
Miha, hvala lepa. Lep pozdrav tudi v mojem imenu. Trendi na področju medicine, ki zajemajo razvoj personalizirane medicine, reinženiring DNK, razvoj inovativnih zdravil in opreme, robotiko v zdravstvu, raziskovanje genetskih in okoljskih dejavnikov bolezni, zbiranje množičnih podatkov o bolnikih, informatizacijo in še bi lahko naštevali, uvrščajo zdravstvo med najbolj dinamične dejavnosti. To je dosežek, seveda pa zahteva tudi njegovo hitro prilagajanje in nove pristope za ohranjanje finančne vzdržnosti zdravstvenih sistemov in implementacijo prebojnih rešitev v prakso. V zadnjih 20 letih smo z različnimi strategijami, kot so krepitev preventive, sistematično vrednotenje novih tehnologij, ne samo z kliničnega, ampak tudi z ekonomskega vidika, uvajanja sistemov celovitega obvladovanja kakovosti in tako dalje, dosegli občutna povečanja učinkovitosti in uspešnosti zdravstvenega varstva. Na žalost pa še vedno nezanemarljiv delež zdravstvenih izdatkov nastaja zaradi neutemeljenih razlik med načini izvajanja in izidi istih zdravstvenih posegov, premajhne uporabe dokazano učinkovitih posegov, razlik v dostopnosti do najučinkovitejših, najboljših načinov zdravljenja glede na bolezen, pa tudi neracionalne prekomerne uporabe zdravstvenih dobrin. Vse to dokazuje, da dosedanji napori niso zadoščali. Ključno vprašanje pa je, kaj so alternative. In na današnjem srečanju zelo me veseli, da je ekipa organizatorjev iz različnih da so predstavniki različnih deležnikov, ne. In na današnjem srečanju želimo nasloviti vprašanje, ali je prava strategija za naprej tako imenovani value-based healthcare. S tem povezane občutne spremembe v procesih odločanja o razporejanju omejenih virov ter krepitev odgovornosti za doseganje relevantnih izidov zdravstvenih dejavnosti. In kot je rekel Miha, se bomo pogovarjali tudi o tem, kaj bi takšen zasuk pri odločanju na podlagi ustvarjene vrednosti pomenil v praksi, in sicer na primeru protonske terapije. Skupaj z vami se zelo veselim današnjih predstavitev in diskusije.
Super, hvala Petra za kratko predstavitev vsebinskih okvirov. Sedaj pa vabim gospoda Marjana Sušlja, generalnega direktorja Zavoda za zdravstveno zavarovanje Slovenije, k njegovemu razmisleku o temi, ki je močno povezana prav z načinom izračuna nadomestil in tudi financiranja zdravstvenih storitev v Sloveniji in kje ima v bistvu ZZZS v Sloveniji ključno vlogo. Gospod Sušelj, beseda je vaša.
Hvala za besedo, za uvod. Vesel sem, da smo lahko v Zavodu za zdravstveno zavarovanje danes na dogodku kot soorganizator. S tem želimo poudariti tako pomen hitrega in stalnega uvajanja novosti v zdravstveni sistem, pa tudi nujnost, da se tiste novosti, ki so dokazano koristne za pacienta, ki so medicinsko priznane in tudi stroškovno učinkovite, da se te novosti dejansko financirajo iz virov zdravstvenega zavarovanja. Kot nam je znano, kot tudi preberemo, se s pristopom value-based healthcare že nekaj časa ukvarjajo pri nekaterih zavarovalnicah v Nemčiji, v Franciji, v Avstriji, v nekaterih skandinavskih državah in na Nizozemskem. Imajo že tudi izdelanih nekaj prvih funkcionalnih modelov. Slovenija se na žalost še ne more pohvaliti z uveljavljenimi rezultati na tem področju, niti še nimamo eksplicitno opredeljene nacionalnega strateškega pristopa. Posledično sicer redke razprave, tudi današnja, ostajajo na nivoju vprašanja, zakaj uvajati takšen način dela in ne prerastejo dejansko v ključno vprašanje načina in terminov uvedbe oziroma implementacije. Z vidika zavarovalnice predstavlja pravo vrednost koncepta value-based healthcare predvsem čim ugodnejši izid in rezultat zdravljenja za pacienta, ter s tem seveda predvsem izboljšanje kvalitete življenja. Vzporedno je ta vrednost seveda tudi čisto finančna, smo tudi finančna ustanova, v smislu, da je metoda zdravljenja dolgoročno stroškovno učinkovita in da so javna sredstva uporabljena na kar najbolj smotrn način. Na Zavodu za zdravstveno zavarovanje se zavedamo zaostanka. Zavedamo se pa tudi priložnosti na tem področju, zato smo si v našem strateškem razvojnem programu za srednjeročno obdobje do leta 2025 postavili kar nekaj ambicioznih in visokih ciljev na področju razvoja na tem segmentu. Za doseganje čim večje vrednosti za paciente in s tem value-based healthcare je namreč bistvenega pomena merjenje izidov in učinkovito komponiranje teh rezultatov v modele oziroma načine plačevanja zdravstvenih storitev. Pri teh razvojnih korakih pa so ključne ustrezne informacije in podatki na eni strani, na drugi strani pa kvalitetni partnerji in sodelavci, ki so pripravljeni raziskati novosti, preseči odpor do sprememb, najti nove rešitve in konstruktivno medsebojno sodelovati. Osebno sem prepričan, da z današnjim dogodkom, ki najbrž ni zadnji v tej vrsti, skupaj z vabljenimi eminentnimi govorci izpolnjujemo to poslanstvo. Torej, iščemo nove rešitve in morebitne nove načine sodelovanja s skupnim ciljem in ključnim ciljem zagotoviti čim višjo vrednost za posameznika, ki mu je življenje preneslo na pot težko zdravstveno preizkušnjo. Želim, da bo današnji posvet potekal kakovostno, uspešno in seveda se veselim razprave v zadnjem delu. Hvala lepa.
Najlepša hvala, gospod Sušelj, za uvodne misli. K besedi in k uvodnemu razmisleku vabim še dr. Aleša Rozmana, predsednika zdravstvenega sveta v prejšnji sestavi. Prav zdravstveni svet ima pomembno vlogo pri oblikovanju vsebine zdravstvenih programov, stališča njihove izvedljivosti, enakomernega razvoja vseh strok in načela enake dostopnosti, pa tudi do razširjenih strokovnih kolegijev od njih lahko zahteva, da strokovno doktrino prilagodijo ekonomskim možnostim države. Dr. Rozman, beseda je vaša.
Hvala lepa. Spoštovani udeleženci posveta o zdravstvu, ki temelji na varnosti. Žal moram na začetku ugotoviti, da so življenjske dobe zdravstvenih svetov, ki so vezani na mandate ministrov, zelo kratke. Tako da se bojim, da tudi v prejšnji sestavi, ki je delovala nekaj mesecev, teh glavnih ciljev niti nismo uspeli pravočasno nasloviti, kaj šele priti k uresničevanju. Sam koncept zdravstva, ki temelji na vrednosti, je sicer izredno privlačen, vendar je sedanjega izhodišča naporen za uresničitev. Smo majhna država s specifičnimi potrebami, hkrati pa smo dokaj omejeni z samimi viri, predvsem kritično maso kompetentnih strokovnjakov in pa odločevalcev. Mnoge ovire nam je nakazala prav ta pandemija, ki nam mora služiti kot učna ura, kateri so izzivi hitrega in nacionalnega odločanja na nastale potrebe. Vrednost temelji na izboljšanju zdravja na enoto stroška, kot je že poudaril gospod Sušelj. To ni najcenejša medicina in tudi ni tista, ki nudi vse, kar znanost ponuja ne glede na korist. Cilj je boljše zdravje, ne pa več zdravljenja. V središču so potrebe bolnikov, od vrst bolezni, njihovih incidenc, prek dostopnosti obravnave do optimalnih izidov. Torej, bolezensko stanje vse od preventive, prek diagnostike, zdravljenja do rehabilitacije in spremljanja v celem krogu obravnave. Pot zaokroži prek primarnega, sekundarnega in terciarnega nivoja, ter se potem znova vrne nazaj na primarni nivo in dolgotrajno oskrbo in morda znova nazaj na ostale nivoje. Tako zdravstvo ima vrednost, če je stroškovno učinkovito. Temelji na sodobni medicini in vključuje bolnika in njegovo lestvico vrednot. Mora biti varno, hitro in enako dostopno vsem. Ključ do tega, kar nam najbolj trenutno manjka, pa je celovita informacijska podpora, ki ne zajema zgolj sprotne izmenjave in dostopnosti podatkov, pač pa tudi sprotno analitiko. Menim, da je to prvi in nujni korak, o katerem smo razmišljali že včeraj, delovati moramo pa danes. Vsem skupaj želim uspešno srečanje.
Hvala, dr. Rozman, tudi za vaš pogled. In sedaj prehajamo na strokovni del posveta, ki bo potekal v angleškem jeziku. We are now moving on to our presentations, which will be held in English. At this point, I would like to invite Petra Dušenović-Bonča back to the podium. And I'll let you share your screen, right? 1 second. There you go.
Okay, thank you very much. So my task today is to start addressing the very important question of why is value-based healthcare essential? We constantly talk about this gap between the demands and the needs of our patients and the available resources. And in Europe, we talk about the threat of this gap to financial stability and universal healthcare coverage. And we also talk about its obstacle to providing the most appropriate care. I think all of us that are present here today are frustrated because we know how to do better, but we're unable to do so. And we've done a lot of different things, as I said in my introduction, many improvements that are highlighted here on my slide. I'm not going to go into them in a lot of detail. But all of these improvements that have been achieved have fallen short. Why have they fallen short? Because we still have some very important and very persistent problems. And some of them are listed here. So we have unwarranted variation of activities and outcomes of interventions. We still have underuse of effective interventions. A very important issue is inequity by disease. A big problem is overuse causing waste and patient harm. And of course, slow spread of best practices and resistance to innovation even. And the question is value-based healthcare a solution? A straightforward question, but the answer is a bit more challenging because there isn't really an agreed definition. People understand the concept differently. And there's this big issue that has been highlighted in the introduction of how do we define value? How do we understand it? Do we all understand it in the same way? And is this really a new paradigm, as was listed on our main title of this event? It's really not a new concept. It was first introduced back in 2001, but it started gaining a broader public attention when Porter published his book on value-based healthcare. So that broader public attention started in 2010. And if you look at the literature since then, you will see that in Europe, the discussion has gone further, stating that the Porter's model is not necessarily very well suited to countries in Europe that are committed to universal healthcare coverage. So in this literature, you will also find the triple and quadruple value model. And I will address some of these things briefly just to kind of see whether these concepts do come together and what are the differences and what are the similarities. First, if we look at the Porter's value-based healthcare, you heard in the introduction, value is defined as health outcomes that matter to patients relative to costs of achieving those outcomes. So this value agenda, it seems natural, it seems logical, but in practice, it will require us to make a lot of changes. So we might even say that it's disruptive, but in a positive way, because we really need that shift from a supply-driven healthcare system that's organized around what physicians do towards a patient-centered system organized around what patients need, so that there's the shift from activity to outcomes. And as I said, this will require massive changes in healthcare systems that we are in a way resisting, because any change is always a problem that has to be, we have to overcome it. So if you look at the current situation that we're in, we are still organized by specialty. When we talk about quality, still we define it very often through process compliance. Cost accounting is something that is interesting to me, and it makes me even angry sometimes that we are falling behind the best practices here. It's still in healthcare driven by charges, not by costs. Payment systems have changed and they have evolved to incentivize efficiency, but they're still not linked to outcomes. Little integration still, fragmentation of patient populations. We have these siloed IT systems, and all of that is not helping to solve the problems that we talked about initially. So if you look at the contributions of Porter and Lee, there's a strategy or this value agenda shift that has 6 components, and they need to be implemented in every healthcare system. Not necessarily all at once, not necessarily all the elements in all the detail, but we have to start somewhere. And because we know all the elements that are needed, we can build towards the end goal. So if I just fly through these elements, the first one is organizing into integrated practice units. Again, sounds logical. We need to move from these siloed organizations by specialty department to organizing around the patient's disease. And we have scarce resources. So this is the key thing that's needed also to boost efficiency. The second topic where I think we have most controversy in terms of understanding what the concept value is measuring outcomes and costs for every patient. This transparency here illustrates the production function in healthcare. And you can see from this slide that we can identify different outputs, different results in healthcare. We can look at it in a very narrow way or in a wider sense. So in a very narrow way, we can just look at the inputs that we have and the amount of healthcare services that we are producing. So we're focusing on volume of services. This is the output that we are observing. But of course, you know in healthcare that you may be getting the best service, but if it doesn't serve the need, if it doesn't actually improve your outcomes, you may be efficient, but it's not effective. This is a good example of wasted resources. And we do have that focus on outcomes already present, but it's still focused on process measures, easy to measure clinical indicators. But we need to add another dimension. Another dimension is, what are the outcomes that matter to patients? So it's not just the outcome, it's how we value the outcomes. And my textbook example that I usually use in class is that if I lose a voice and someone else loses their voice and we regain it through effective interventions, I'm pretty sure that I would value that outcome differently given my profession and given that I rely on my voice for my professional career. So there is this difference in how you look at the result of what you're doing. And what's also important is that you have very different stakeholders that, of course, look at this chain that's shown on this slide. So for value-based healthcare, it's important to look at outcomes that are relevant, that matter to patients. they need to be about the medical condition. And what's important, and sometimes we forget about that, outcome measurement has to be linked to measurement of risk factors as well. And we'll have to accept the necessity of public reporting down the line somewhere if we want to have accountability. Now, Porter introduced a three-tiered hierarchy of outcomes. So we are not expected to just look at health status that is achieved, but also we need to look at the nature of the care cycle, the processes that patients go through, and of course, the sustainability of health. And why is this so important is because if you look at these different outcomes that we will end up measuring, there's a trade-off between these outcomes. And the key thing here is that these trade-offs actually will drive innovation because we'll try to address them. In terms of costs, I really like this statement by Porter and Lee. The absence of accurate cost information is nothing short of astounding. I agree, and I said that initially, especially in Slovenia, the accounting systems are still very much focused on actually just supporting the money flows between the payer and the hospitals, and they are not there to serve the management and organization of healthcare providers. And oftentimes when you talk about cost accounting, we kind of dislike it, but we need to understand that it's not a foe, it's a friend. It's something that will be necessary. If we look at payment, we will need to move to bundled payments. If you look at acute medical conditions, bundled payments cover the full cycle of care. If you look at chronic conditions, we will have to cover a defined period, costs that emerge and outcomes that are created in a defined period. If you look at primary or preventive care, a defined population has to be covered. And you have a few conditions that need to be met here, listed on this transparency. Again, focus on a condition. It has to be contingent on delivering good outcomes. It has to be adjusted for risk, and it has to incentivize providers as well. It has to provide a fair profit. In Slovenia, the word profit is sometimes considered to be a kind of a devil. We don't even use it, actually. We talk about access revenues over costs, but you need that in healthcare. And having non-profit organizations doesn't mean that there's no profit there. It just means that the profit is not, of course, taken out from the organization by the owner. So we need to also change the attitude here, because we need to incentivize the innovation. And of course, there has to be some protection of providers as well. The fourth element is integrate care delivery across separate facilities. As specialization increases, we know more, the knowledge is progressing very fast. We can't be a jack of all trades, because a jack of all trades is a master of none. So if you look at organizations, they have to define the scope. They need to identify what they're good at, concentrate volume in fewer locations, because we need to exploit economies of scale and mind quality as well. So there's going to have to be that separation, but then of course of what individual organizations do, but then integration of care and cooperation between them. And that's linked to the fifth element, expand excellent services across geography. If you have different providers, of course you need to combine them in a network so they all contribute. And in terms of IT, currently our IT systems are siloed by department. They complicate rather than support care, and we need enabling IT systems. One thing that's very important is, today I think many healthcare professionals are frustrated because they are collecting a lot of data, but they don't get feedback. And if you want to have quality data, you need to have feedback to providers. If they know why they're providing the data, they're going to take care of the data, because they know that it serves their purpose and it supports their purpose. In Europe, as I mentioned initially, this Porter's view has been considered too narrow because of universal healthcare and the solidarity principle. There's this notion of optimizing value for the whole population. And you will find in the literature the so-called triple value model. And I guess this figure here on the next slide illustrates how these things connect. The first very important task we had the representative of the payer. So the first important question is allocative efficiency. So we need to address the question of how much money are we going to, of course, allocate to healthcare. The second question then is, how should the resources that are then available for healthcare be allocated to different population subgroups of programs? And there's this big shift from allocating resources to hospital care, primary care, secondary care, long-term care. We need to move from that and allocating according to a common need of the population. So either program budgeting can be used, and given that many people have more than one condition, another approach is also allocating according to common characteristics. So once you know how the money is allocated to different programs, then the question is, how do you allocate then the available resources within each program? And here we come, of course, to back to the narrow view, in a sense that then when you allocate to different interventions, you need to, of course, keep in mind patient outcomes and patient characteristics as well. More recently, this triple model has been extended to the so-called quadruple model, and the European Commission's expert panel has added a societal value dimension as well because of solidarity in Europe. So now in the literature, you have this discussion not about just value-based healthcare, but values-based healthcare as well. Now, there's an interesting paper that you might want to read if you are interested in this field. They looked at value-based healthcare in 4 different healthcare systems, and the paper confirms what I've said. There's still uncertainty about what the term value-based really means. Experts understand it very differently. And also what is important is that the implementation status varies considerably across countries if you look at the model that I've introduced previously. So just briefly, because I have very limited time, an interesting result from that study actually showing you that there isn't a country in the world where all of these 6 elements are already fully developed, nor are they, fully on a national level. So you have either pilots or regional initiatives, but this is okay. We need to start somewhere and build from there. So this is a good piece of paper to read. Now, I just want to address 2 more things that I think are very specific also, or very interesting, or very relevant for the Slovenian context, because we are, as stated in the beginning, we are lagging behind best practices in Europe, and there are many misconceptions about what do we mean by bundled payment and value-based healthcare. And many times, we say we have DRGs. We've bothered with that in the last decade or so. We've introduced DRGs in 2004, but we're still struggling with adjusting that to the Slovenian context. But DRGs are not the same as bundled payments. So, we need to get a hand of that and then add another very complex dimension to that. And what DRGs have done is they have incentivized efficiency, but we need to go beyond that. And in addition to rewarding efficiency, we also need accountability for the standard of provided care. Another very important issue is value-based care versus cost-effectiveness analysis. Those of you that work in healthcare, and you've come across that, we have value-based healthcare, and we've defined value as health outcomes achieved per dollar spent. And in cost effectiveness or cost utility analysis, we are looking, again, we are comparing costs and benefits of our alternative interventions, and we are, of course, aiming to select those interventions that, of course, perform better. So in both approaches, we consider costs and outcomes. So what's, the difference, or what's the similarity? And there are quite a few similarities. I don't have time to dig into them. I'm just going to stop at outcomes because in cost effectiveness and cost utility analysis, the outcome measure is combined in a single metric. Most commonly now, the quality adjusted life year. In value-based healthcare, outcomes are a multidimensional concept, and we want to look at what matters to patients. And there are pros to cons to both approaches, because remember that in Europe, we are very, focused on allocating equitably the available resources between different programs and different disease areas. So when you're, trying to support those decisions, you need to have a metric that also allows you to make those cross-program comparisons. So, you know, value-based healthcare and cost effectiveness or cost utility analysis, as stated by the two authors that are of this interesting paper, they state that they are health economic siblings. So they need to meet, align, and work together. And there are some important lessons that, you know, can be learned from both approaches. Again, I can't go into all of them, but I think I've mentioned the most important one. In cost effectiveness analysis, it's important to find ways of actually, you know, taking that multidimensional outcomes into consideration. But in value-based healthcare, there's this limitation as well, because you need to have, you need to support decisions about, you know, allocating available resources across different population groups. So cost effectiveness analysis is one, but not the only input for delivering value-based healthcare, but they're definitely not the same thing. Instead of a conclusion, and I think I've taken a bit more than 15 minutes, we could have a poll right now, and I could ask you, do you believe that this paradigm can transform healthcare? And you might probably say, yes, we believe that. Are you among the skeptics? And you would again say, well, yes, you know, I do believe, but I have a lot of concerns. So, you know, bundled payments are too complicated. The healthcare system is complex as it is. But I think we agree on one thing, all of us present here today. There is a way to do it better. And we're here because we want to find a way to make it better. Thank you.
Thank you so much, Petra, for your presentation. Hvala, Petra, za tvoj strokovni pregled in tudi zaključek, ki kliče vse deležnike k razmisleku, kako lahko tudi v Sloveniji naredimo korake naprej, vse z namenom optimalne oskrbe bolnikov na eni strani in vzdržnega zdravstvenega sistema na drugi strani. Izkušnje z Združenega kraljestva pa nam prinaša gospa Katja Grašič. Let's hear about the situation and experiences from the UK. Katja Grašič, the floor is yours.
Thank you. Thank you very much. I'm going to have my presentation in English, but I'm happy to take the questions in Slovenian languages, in Slovenian, if that's better. So my presentation is going to focus on hospital reimbursement and how to incentivize quality within developing new reimbursement systems. So first, I'm just going to quickly go over how hospitals are paid, what are the different reimbursement systems, and then I'm going to focus on incentivizing quality of care. We're focusing on pay-performance schemes. I'm going to give you an example of a scheme in England that we evaluated together with my co-authors. These are James, Nils, and Luigi. So the main systems of payment for hospitals are fee-for-service. This is the simple one. Whatever you do, you get paid for it. So for each injection, for each treatment, you get paid for it separately. This one, it's believed that it raises costs because there's no incentive to reduce the cost, to increase the efficiency. It's one of the prevalent systems of reimbursement in the US, but it's also present in many European countries, at least in some segments. So for example, some family physician, some hospital activity will be paid fee for service. The other one that was prevalent until beginning of 2000 in most countries is capitation, where hospitals get paid a fixed sum for each patient enrolled in their hospital. So this is usually adjusted for some characteristics. So it's based on patient's age, demographic things, but it doesn't incentivize physicians to perform. Well, it doesn't really incentivize them to perform any additional treatments. It doesn't even incentivize them to perform the treatments they're actually supposed to do. So this is a common method for reimbursing the family physicians, so GPs, where physicians are paid per patient. But we've moved from that. We've moved from the fee for service, we've moved from capitation, and I think most OECD countries now are firmly in the DRG-based payment domain. In this case, hospital gets paid for the entire patient pathway. So based on the main diagnosis, main procedures that were done, there's one single payment to the hospital. So this does incentivize efficiency in a way, because hospitals does not receive any extra money for any additional procedures that are not necessary. But however, it's still based on quantity rather than quality. So despite everybody saying the DRG is, increases efficiency, it increases quality as well, the quality bit is actually we're not so sure about, because there's nothing that measures quality in the DRG system. So in order to increase the quality element, so in order to increase the value, we could say, in many countries now, so in most OECD countries actually, they've started to implement this, it's called pay-for-performance schemes. So they link the payment with specific quality measures. There's a wide variety of different schemes out there. So there was a review recently of schemes in 32 different schemes in OECD countries. And it showed there's a lot of variety in what's incentivized. So it's either to reduce the mortality, readmissions, or very specific measures. So they can work either as carrot or stick. So they can providers can either get more payment if they do, if they provide quality, or they don't get payment. This is, for example, in UK, this holds for readmissions. So for certain readmissions, hospitals won't get paid if a patient is readmitted within 30 days. So it's kind of a stick element. There's no rules of how the incentive looks like, because different countries, different healthcare systems have different priorities and therefore incentivize different measures. So, as I said, there are examples of these programs across the world. It's popular in the US as well. It's quite high on the agenda in the UK at the moment. And it's been around for 10, 15, 20 years. And still, we're not really sure how well it works. I mean, despite what I've said now about it increases value, the reviews actually so far say, well, not necessarily. Many reviews show that even if they get paid a bit more, providers don't necessarily take up the incentive. This can be due to various reasons. Maybe they don't believe in what's incentivized. Maybe it's just too much work. Maybe the incentive in many cases is just too small. So one of the reviews showed that most of the incentives were 1% to 2% additional revenue, which probably wasn't enough to change providers' incentive, especially because there are some costs at the beginning before you implement a new scheme. So in our research, we try to see whether, if you design a scheme very well, will you get quality improvement? And I'm going to present you one of these schemes. So this scheme is called Best Practice Tariff, and it's aimed for fragility hip fracture patients. So it's only incentivized hip fracture care in this case. It was introduced in 2010, and it has a very interesting design. So providers have to meet 9 different care criteria in order to receive bonus payment. So these criteria were designed together with clinicians. So it was quite clinician driven. So it was based on the best available practice. The criteria include surgery within 36 hours, just because most studies show that the sooner the patient is operated, the better the outcome. And it also involved a lot of geriatricians in the care. So if you look at BPT2, it's shared care by surgeon and geriatrician. So they really want to emphasize the role of geriatrician in care of elderly patients. So many of this criteria, so it's shared care by surgeon and geriatrician, it's care protocol, again, agreed by geriatrician. And we also have here perioperative assessment by geriatrician. So perioperative means just before the operation or during the operation. And geriatrician-led multidisciplinary rehabilitation. So there is the strong role of geriatricians in the care. There's also cognitive function assessment, and then prevention of falls and bone health assessment. So providers have to meet all these 9 criteria for each of the patient to get this extra payment. The payment is quite significant though. So when it was introduced in 2010, the payment was £350 per patient. But this now increased, and in 11-12 it was £800, and now it's almost £1,400. So this is 20% of the base tariff. So this is a big incentive, considering that usually it's 2 to 3% extra that they get. So there is a large financial incentive. So how they did get to this incentive? So the national healthcare system, so NHS, it's not paying more. The base payment reduced a bit. So in total, the net is zero for the payer, because it's kind of it has the stick and carrot element. So they get a bit more, but they're also getting paid less if they don't do it. And it has this bundled payment arrangement. So bundled payment arrangement is a word that has so many different meanings in healthcare, but in this case, it just means it's all or nothing. Either you get all 9 criteria and get the payment, or you don't get the payment. So just meeting 7 criteria won't do anything. So we had 2 main research questions. So what is the effect of the policy on achieving this criteria? And then we also looked at how this affects, I mean, if you meet the criteria, does it affect the mortality? Are patients better off? So there are many ways we can measure patient quality, with survival rates being one of the most common ones. So I'm not gonna have time to answer this question. I can just tell you the answer is yes, but if you want more about this, I can tell you about it in the discussion. So to answer all these questions, we used a difference in difference approach, where we compared care in England to care in Wales. So I'll talk about this a bit later. Wales and England have different healthcare systems, but they're very, very, very similar. In this case, only England had the incentive, so we were able to compare the care across both countries. We got the data from the National Hip Fracture Database. So this is a quite rich database that has information on all hip fracture patients over the age of 60. It has information on demographic information, on age, gender, social status. It has also information on clinical information. So it has information, for example, on all this BPT criteria, but also on how well they were when they came in, what their predicted mortality score was, and things like that. So we use several control variables to control for differences in population across England and Wales. So age and gender, admission source, so whether they were admitted from a care home, for example, or from home, or they already were in hospital in many cases. So clinical characteristics, type of fracture, and patient-reported mobility, so whether they could walk before they fell or not. Our study period is from April 2008 to March 2015. So the pre-policy period is April 2008 to March 2010. We have 2 pre-policy years and 3 post-policy years. And we have around 300,000 patients, 14,000 from Wales. So as I said, England and Wales have different healthcare systems, but they are very similar. So both are tax funded, similar spend per head, and also all the regulations that could affect the care are the same across countries. So the clinical guidelines are both the same. So because when you do this kind of type of analysis, you do have to make sure that you're comparing as like with like as you can. So if they had any different care system, the comparison wouldn't make that much sense. So this is our main regression specification that we did. So if you look here, this England DT, this is the dummy for pre and post policy period, because we compared how well England did past after the introduction of the policy. And so England is dummy, whether it's England or not. D is dummy for pre and post policy period. and or main outcome Y is 1 if they meet all the criteria, 0 otherwise. So because the criteria were introduced at different time, the main analysis just looks at the ones that are constant over time. We've done loads of sensitivity analysis looking at other ones, but I won't have time to talk about it. We of course include also patient characteristics as controls, year dummies, calendar months, because winter months are different, for example, for care compared to other months, and hospital fixed effects. We also look at how the bonus increased over, because the bonus increased over time, we also looked at how the response was over time. So did English hospitals improve further once the bonus increased, or was their response the same over time? And we also do loads of sensitivity analysis just to check whether our results are robust. And this is the overall achievement graph you see. So this takes into account 7 different criteria, the ones that were constant over time. You see pre-policy, this is before the dotted red line. It's basically flat for both countries. So both countries start at 0. Over time then, England shoots up. So they reach almost 70% by 2014 in only a few years, whereas Wales, where there was no incentive, stays more or less at 0. So like this is, I find this graph quite powerful. It shows like you pay them more and this is what you get kind of thing. So this is also confirmed by our regression results. So it says that the policy improved the probability of meeting the criteria for English patients by almost 52 percentage points, which is a lot in any standards of pay for performance schemes, where you usually get a very small effects. I mean, this effect is large. And we also see that it was already large in the first year at 30 percentage points, and then it kept on increasing over time as the bonus increased. However, I said that they have to meet different criteria to get the bonus payment, right? And we also looked at, for each criteria, how well the response was. And we see this is the results of individual criteria. So the same regression as I showed before, but on individual criteria. And what we see is the biggest effect is actually on any criteria that's dealt with geriatricians. I think there's quite a simple explanation for this, is because to get geriatrician involved in care, English hospitals had to hire new geriatricians. They could offset the cost of hiring geriatrician by getting more money. Wales didn't have that, so they couldn't afford geriatricians. They still improved in other segments though. So I think I have a graph in the end, I think, that I can show you to see that, you know, Wales still improved, just not consistently over time. Actually, I'll just show you this graph. So you see BPT2, for example, this is shared care between geriatrician and a surgeon. In England, it reaches 100% almost immediately, where it stays flat, almost 0 in Wales. Whereas other criteria, so BPT7, for example, it's both countries improve. So this is the, I think this is bone health. And we see there are differences across criteria. In most criteria, also Wales improves, but there are some where only England will improve. So our study shows that if you design it well, it can work. It can actually improve the quality of care for patients. I didn't show now, but we also find that it improves mortality. So it improves survival rates. And doesn't really have any unintended consequences that you sometimes get in schemes. So whatever we looked at, actually there was nothing wrong with the scheme as such. There are some things that sets it apart from other similar schemes that were probably less successful. One is probably the bonus size. I mean, probably the biggest single thing, if you have to point one thing out, is 20% bonus compared to the base value, which compared to usual 2 to 3% is a lot. And this bundle payment arrangement, where I have to meet all the criteria compared to meeting only a few of them, if there wasn't a bundled payment arrangement here, they might not decide to hire geriatricians. They would just do all the other criteria that would pay them anyway extra without going through the trouble and additional cost of hiring geriatricians. And the criteria were based on clinical guidelines. So they were accepted by clinicians just because they made sense. It wasn't something that came up in somebody's head, but it made sense, and that's why it was accepted by clinicians. Okay, that's all from me. Thank you.
Thank you so much, Katja, for sharing that with us and showing us all that change is possible. I believe we can learn a lot from good practices from abroad. Torej, hvala, Katja, za predstavitev izkušenj, ki kažejo, da so spremembe možne, in verjamemo tudi, da se lahko veliko naučimo iz dobrih praks v tujini. Naslednja govorca pa se bosta že bolj usmerila na specifično področje onkologije in še posebej obsevalnih terapij. Let's shift our focus even more specifically on oncology and radiation therapy. First, let's welcome Professor Joseph Maria Boras. Professor Boras, it is an honor to have you with us today. Please, the floor is yours.
Okay, thank you. I will try to find my presentation if I can, well, now I don't find, so it's, let me check if I have open. Yeah, now it's open. Okay. Okay. Well, my talk will be based on focus on radiation oncology, and I think I would like to discuss that from the traditional approach in radiation oncology, that it's based on need, so the optimal utilization of radiation oncology, and then to move to value-based cancer care and in radiation oncology and the problems of that could we can envisage in radiation oncology to apply the value-based framework, and also to discuss the example of proton therapy as a good example of these difficulties of the thing. So the outline will be the classical approach, then the assessment of reimbursement, challenges in evaluating the value framework, and the proton therapy as an example. What are the classical problems in radiation oncology? First, where the more classical was waiting list, then the update of technology, then the possibility of comparing countries and comparing hospitals in terms of activity and in terms of, in some cases, even in outcomes, and then discuss the cost, because the radiation oncology, the main difference between radiation oncology and medical oncology is that in medical oncology, the cost of drugs, it's more or less integrated in the annual cost of the hospitals, but the radiation oncology, when you need to invest in a radiation oncology facility or equipment, you need to find the money to pay for the investment. So the upfront cost, it's very high in comparison with maintenance or the running cost. So the first thing that we did in radiation oncology with an ESTRO group, the European Society of Radiation Oncology group, was to compare the situation and to facilitate to the national societies the situation of different countries in relationship with the facilities in radiation oncology, in treatment, in radiation oncologists, in medical physicists, and also in technicians in radiation oncology. Here you have an example of the analysis that we did that showed the highest variability across the countries in terms of radiation oncology. And the next question was this availability of resources related to the GNI, the gross national income per capita by the country? Because one question that you can see, that you can guess, is that the availability of the equipment is associated with the resources of the country. Here you have the comparison with GNI and the megavoltage units with image guidance radiotherapy, which is a technologically, let's say, advanced technology in radiation oncology. And you can see that there is a good relationship between the both variables, but there are outliers. So there are countries with a high percentage of, let's say, technologically advanced machines, but without, let's say, a higher level of GNI, while there are other countries that it's just the opposite. So there is a clear overall socioeconomic bias. A higher GNI does not necessarily translate in more radiotherapy resources. So policy matters. So the policy decisions of the policymakers clearly make a difference in different countries. That was perhaps the main differences in these studies that we did. The next step was to compare reimbursement for radiation oncology and the resources involved in radiation oncology. And first of all, there was a need to assess the access to radiotherapy around the world, and there were models of economic investment in radiation oncology that were developed for the utilization of different national societies and also international organizations. And if, for instance, if we compare with data from Deloitte in a document published a couple of years ago, that comparing the data in 2004-2014 in radiation oncology, we see that regarding all the cost per patient and average cost per patient in radiation oncology was 4% of all the cost in cancer care, both in the year 2004 and 2014. While, for instance, if we compare with chemotherapy, the chemotherapy was at the beginning was 15%, and then in the 10 years later was 20%. And the other factors were more or less similar, or even reducing the contribution of the percentage. So what we can see is that radiation oncology, in terms of total cost for cancer care, it's a small part of the total cost of cancer care. This was global data based on essentially in American data. What we did an analysis in Europe with the countries that we have the data. And what we see is that essentially it's about 7-8%, the average total cost of radiotherapy in relation with the total cancer care expenditure. And if we compare with the total healthcare cost, radiation oncology accounts for 0.4-0.5% of the total cost. So radiation oncology, it's really globally, in relative terms, quite cheaper in relation with other activities in cancer care. However, when we analyze the reimbursement in Europe, what we see is a very, a range of variability in approaches in reimbursement, from the budget, the classical budget approach, to something really fee for service, so essentially paying for each of the activities involved in radiation oncology, also some kind of bundled payment or episode-based payment, which in radiation oncology, it's quite easy to manage, because the radiation oncology therapy, essentially, it's very well defined in time. So what we can see is that the cost of radiation oncology is quite low, but the way of reimbursement, the variability, it's very big, and it's quite constant and has not changed with the innovation that we have seen in radiation oncology in the last 20 years. So one of the results of this is that, for instance, treatments in radiation oncology, the reimbursement by country, it's very different in the amount of money reimbursed, and even in the criteria. For instance, in the Netherlands, it's the same in breast cancer, the standard fractionation, that hyperfractionation, that accelerated fractionation is reimbursed exactly the same, while in Denmark, for instance, there are quite different reimbursement for the same therapies. And this also happens in prostate cancer. So this variability, it's not only the model, it's also the price reimbursed, because, well, this price, it's adjusted for PPP differences among countries. So we have discussed this in our European project, the Innovation Partnership for Action Against Cancer, that is Slovenia. In fact, the National Institute of Public Health of Slovenia is the coordinator for this European joint action between the European Union, the Commission, and the different countries. And one of the main things that we have discussed is precisely how we can change the reimbursement models in European health system for radiation oncology and complex cancer surgery. We have found that there is a lot of data regarding the reimbursement of drugs, but not so much data regarding reimbursement of radiation oncology and complex cancer care. And what we advocate is episode-based payment based on the utilization of resources with clinical and administrative data collection and support for improved quality management of the care. And when we talk about emerging innovation, that in radiation oncology, like in complex cancer surgery, there are many activities that could be qualified as emerging innovation, changing the patterns of care. The coverage with evidence development, that there are good examples, for instance, in Belgium, could be a good option to support the introduction of the innovation, collecting the evidence, and then deciding if the innovation is worth to finance in the future for the company. So the other and the main topic of this session is about value. Value, as has been mentioned, it's health outcomes that matters to patients and related to the cost. That was classical definition. In oncology, we have at least three. There are some others, but the main scales have been trying to measure value of oncology. In oncology, have been focused on drugs, only in drugs, and has been developed by professional and scientific bodies related to medical oncology. Here we have the three main examples. There are differences in the way they assess the magnitude of benefit, so the value. In several cases, even the cost is not stated, so it's not included in the assessment. But perhaps the main problem from the radiation oncology perspective is that outcomes that are strongly relevant in radiation oncology, like treatment-related mortality, local regional control, organ preservation, or reintervention, has not been included in several or almost in all of the scales. So these are scales that are useful for drugs, but probably they are not useful for surgery and not useful for radiation oncology. So the measure of the value and the definition of the value, as it has been mentioned before, it's really an issue that should be considered. And from this perspective, different scientific societies at the European level have been trying to support, and well, the European Society of Oncology Value Healthcare Project, that it's trying to define the priorities and the criteria that we need to assess the value of the treatment in radiation oncology and in complex cancer surgery, in fact. So finally, I would like to make a brief comment regarding proton therapy, because it's an example, it's a good example of the challenges in assessing innovation and reimbursement and value in radiation oncology. Why? Because if we briefly summarize the challenge posed by innovative therapy like proton therapy, we find that the problem is the cost. So there is a high investment to be made in radiation oncology, and then this has been really a barrier to have this therapy. Linked to this barrier, the high investment required, well, not so long time ago, it was about 100 million euros. So now it's about 40 million euros, depending on the machine. So the linked to this is the evidence. There is any review of the evidence, especially from the perspective of health technology assessment, say, well, there is a lack of enough evidence. Well, the problem of the evidence is because if we don't have facilities to carry out randomized control trials, it's almost impossible to have evidence. So For many years, until 5 years ago, in Europe, we have 2 or 3 facilities. So it's essentially were devoted to pediatric oncology. And also many of the indications in radiation oncology for proton therapy are essentially pediatric tumors, and pediatric tumors also it's a rare tumor. So it's difficult to bring together all the patients that require this kind of treatment to be to build the randomized clinical trial. There is a convincing data from radiobiology, but this is enough. The limited number of cases also make problems in this case, but also the fact that there is evidence from radiobiology, probably it's from the health technology assessment perspective, it's not enough, but from the perspective of the clinicians involved in this, it's more than enough. So this kind of discussions about the balance of the evidence and how we need to find the evidence and how to build the data, it's really, I think it's a good example of the problems because if there is no evidence, there is also the policy makers' reluctance to invest in this kind of facilities. So it's like a really difficult situation. Also, patients, well, obviously they perceive better outcomes in some tumors, essentially pediatric tumors, and the toxicity issue also that probably proton therapy could demonstrate. I think this is the consensus in the field that the toxicity is much lower because of the radiobiology of the proton therapy. Also, in providers, well, one of the advantages and one of the main reasons that essentially in the US there are a lot of providers that have decided to invest in proton therapy is that they feel that there is a competitive advantage. This is something that it's reasonable from maybe from the investment perspective, but from a public health sector perspective, it's much more difficult to consider. The other issue is that when you need to build a facility with such a high investment, you need to build partnerships to cope with investment. And then this needs to build alliances among the clinicians in different providers, in different hospitals. So this is another issue that sometimes it's difficult to find the proper way of collaborating, although there are very good examples in different countries. Probably Sweden is the best example of finding really an agreement between all the clinicians involved in radiation oncology to coordinate the different activities to support the facility of radiation oncology. So I think radiation oncology, proton therapy, it's a very good example of the challenges we have to find with emerging innovation that involves a high investment. Probably the running costs are very comparable with other facilities, but the initial investment is very high. So, and this is really something to consider. But things are changing, and I think this is important. The investment, the cost of the investment now it's decreasing, and clearly is decreasing. The facilities are growing. There are I think now around 15 or 20 facilities in Europe working and or almost in the final steps of the capacity to provide clinical activity, and then this will make the trials more feasible, and then the evidence easy to build. Also, real-world data could be available to complement trials, so we will have data about the patients that we treat. Patients they will have better knowledge of the evidence for a specific innovation, and probably in terms of providers, I think the need to reach agreements at a national level or at regional level, it's something that it's more or less evident, and also at the European level, there are some support for doing this and departments of health. So I think also at organizational level, the situation is changing, and proton therapy it's contemplated with a more positive approach for different places. So what we need is data to build policy, to join scientific developments, methodological translation and practical applications based on an organized approach to guide the investment needs and to support policymakers in taking informed strategic decisions. So I think that the ESTRO has done a lot of very good work doing that, and the data is there to support strategic decisions, like, for instance, the proton therapy decision. So in summary, reimbursement, I think we need to focus on complete care cycles of treatment separately for each therapy in cancer care. So the cycle of treatment for medical oncology, for radiation oncology, or for surgery, it's very different. So we need to assume that there should be different approaches for each kind of therapeutic strategy. We need to measure outcomes adapted to the therapeutic objective of the treatment. So if the treatment, the aim is local control, we need to assess the value of the treatment in terms of local control, not in global survival, for instance. We need to support innovation with coverage with evidence development within the framework of a learning healthcare system. So based on the real world data. And proton therapy is an example of the challenges faced by radiation oncology to disseminate innovation, lack of facilities because the evidence it's difficult to collect if we don't have facilities. So this kind of interaction between barriers, it's really important. Now the high investment has been reduced, so probably now it's manageable if positive policy decision. But it's a centralized facility that requires building alliances, in some cases, even in an international perspective. So thank you, and that's my presentation.
Thank you very much, Professor Boras, for your presentation. Hvala profesorju Borasu za njegovo podrobno osvetlitev izzivov in priložnosti na področju naprednih obsevalnih tehnologij in terapij. At this point, I would just like to say that we noticed some of you posting questions and would like to encourage you to do so in the next presentations as well. We will answer your questions at the end of our event, so you can still post them in the chat. Naš naslednji gost pa je strokovnjak, ki vsakodnevno živi izzive najnaprednejše obsevalne terapije za zdravljenje raka s protoni, Matthew Palmer. Matthew, we're very excited to hear your presentation. Please, the floor is yours.
Thank you. Yeah, I appreciate it. Thank you guys for your attention today. I'll be talking about the proton therapy value proposition from the clinical and economical considerations. I have 20 years experience within radiation therapy, both on the clinical and administrative side. In the last 10 years, I was at the MD Anderson Proton Therapy Center in Houston, Texas. Okay. There are 4 eras of radiotherapy, and each one of those, the overarching goal was to better patient treatment. So the fundamental impetus for the improvements were to find effective disease control and improving quality of life. The curiosity of physicians, physicists, and biologists are what led to all the different technological developments over time. As you can see, the linear accelerators back in the 50s were very large, similar to the proton therapy systems today. The goals of radiotherapy are to maximize disease control, minimize both early and late side effects, preserve organ function, preserve quality of life, and minimize extra radiation dose to the patient. And the famous Herman Suit said, one cannot have radiation-induced side effects in tissue that does not receive radiation. So through the iterative process, we begin to look at ways to optimize the treatment plan for the patient, and we find different beam angles and we find different approaches, each iteration lowering the amount of radiation to the patient. And you can see in this example, we were able to reduce the dose significantly, but we also can do that through changes in technology. And you can see that we were able to achieve the highest level of plan through the implementation of intensity modulated proton therapy, the most advanced form of proton therapy. So the development of particle therapy, even stretching back to the 50s, was a response to that need to preserve normal tissue and reduce the side effects. So with that being said, you can see that there are clinical benefits, but as Dr. McClure, Dr. Hahn, and Dr. Beckelman from the University of Pennsylvania stated, could proton therapy be the next disruptive innovation based on these dosimetric benefits? And they described disruptive innovation as something that transforms the markets and replaces existing technology, but it has to be convenient, affordable, accessible, enhance patient outcomes. Most innovations within healthcare are actually sustaining innovations, and they're just stepwise improvements. And one example is IMRT. Using a traditional linear accelerator, they were able to do intensity modulated photon therapy. Typically, these are also more costly and complex. And we can see as radiation therapy developed, the advent of the CT scanner and the development of a multi-leaf collimator are what helped propel intensity modulated photon therapy, otherwise known as IMRT, into the forefront. And as you can see, the same skepticisms that we see with proton therapy currently were existent back in 2002. The space, hardware, software, time, and expenditures to do this technology. Disruptive innovations, though, need evidence development, and the way to assess value could be evidence-based medicine, health technology assessments, or comparative effective research. And so when we look at evidence development from a proton therapy perspective, there was a publication that stated that the average time to publication is about 7 years. So if you take that in consideration with protons, the first hospital-based proton center was at Loma Linda in California in 1990. At that time, there were already 1,000 photon linear accelerators throughout the world. The first proton facility was at a comprehensive cancer center, was at MD Anderson Cancer Center in 2006. So when you plot the growth curve for the US and the growth curve for the internationally looks exactly the same, if you add those 7 years to it, you can see that the majority of the evidence due to when these facilities have come online is really going to be coming later in this decade. And so if you take it as a snapshot through 2020, only 12 centers in the US are contributing significantly to evidence development. So when you look at how does proton therapy become disruptive? Right now, there are high costs and there lacks evidence regarding its clinical effectiveness. But it can be disruptive if there's significant improvements in the innovation that reduce the overall cost, and we continue to develop evidence that mitigate these clinical uncertainties. So when we compare the overall development of photon therapy to protons, with the red line being photons and the blue being protons, there's about a 17-year lag in technology. You can see that photons was adopted more readily because of the cost, and then we had advanced technologies like volumetric arc therapy, addition of cone beam CT, and even the advent of an MR-Linac added recently. Within protons, the first intensity modulated protons was in 2008, whereas the first intensity modulated photons was in 1992. So we're trying to narrow that gap, and there's a lot of development that is underway to narrow this gap even further. The promise for proton therapy is intensity modulated protons. So when you compare it to photon-based treatments, there's radiation throughout the whole patient. The traditional radiation protons, which is called double scattering, actually has a better profile, but the high dose of radiation is still not very conformal. When we get intensity modulated protons, you can see the balance and the benefits of both high dose and low dose. Now, how is proton therapy going to make the change? And as stated before, it is more costly than other radiation technologies, and the costs of the centers are actually a lot more expensive as well, on the magnitude of 3.5 to 4 times a photon vault with the equipment. The operational costs are also more expensive, and also from the payment perspective, and this is pretty consistent throughout the world, that it's about 2.5 times to 3.5 times more than photon-based treatments. And then you have to take into account, because there aren't that many centers, there's additional costs of travel, temporary housing, childcare, and lost wages. And this study was done in the Netherlands that showed that when you take the cost between a proton and photon, the actual cost was 3.2 times more. But as time has evolved, the technology has advanced as well, and the size of the equipment has come down significantly, even to where systems are now can be treated in an upright position with a CT scanner above it. I apologize, my throat, I have a dry throat. Also, that has translated into differences in the floor plans and building design. All of this overall reduces the cost of proton therapy and the implementation. And when you look at even looking at the upright patient positioning compared to a traditional gantry, it has a lot of promise to even further advance the field. Now, with evidence development, it can take years or even decades to get the data. A second concern is potential lack of clinical equipoise regarding proton therapy compared to photons. And some experts have argued that neither patients nor providers would prefer to have more healthy tissue exposed to radiation, and that the idea of requiring a randomized controlled trial in this setting for some disease sites would be unethical. And this question was posed by the late Dr. Cox, who we worked with, and Dr. Goyden: should randomized clinical trials be required for proton therapy? And in there they stated, would we agree to receive 20 in our abdomen with no credible hypothesized medical benefit? And they said, if no, then the burden of proof goes back to photon therapy. Challenges with high quality, high level evidence in radiotherapy is, as new technologies develop, evaluation is initially focused on safety rather than efficacy, and adoption of those can be theoretical and or perceived. Sometimes these studies require significant academic funding, and in order to be a randomized level 1 evidence, it has to be multi-institutional. So that's very difficult. High quality evidence for clinical benefit is less common and frequently based on observational studies, and in radiotherapy, it's not uncommon for a clinical trial to be carried out after the adoption of a new treatment approach. Now, some have noted that there are several potential problems for randomized controlled trials for new technologies in radiation oncology, and one is the double blinding. Because the patient is going to see what technology that they're getting, they're not going to be able to be blinded from one or the other. Other reasons are several cancers now have good local regional control, and you can't really improve that any further. So really what we have to look at from a patient perspective is the patient-reported outcomes and the quality metrics that are important to a patient. Also, the very rapid pace of change in radiation techniques and treatment protocols. I was involved on the clinical side in the first randomized controlled trial for protons for non-small cell lung cancer. And the rapid pace that we were able to change our techniques for intensity modulated radiation therapy and proton actually had an impact on the trial while it was ongoing. We mentioned the ethical idea of clinical equipoise, and then also there's potentially large anatomical differences for some patients, both in the normal, for the normal and tumor volumes. So there's no international consensus on the best approach to develop this high level evidence, but some proposed options are to look at tumor types, and there's some papers that have demonstrated a modest level of evidence for a narrow list of indications. You can also look at the anatomy, location, and size, the ability to spare the non-target tissues around it. Also age, it's generally accepted that pediatrics and young adults would benefit from protons due to the risk of severe late effects and secondary cancers. Also, it's been demonstrated that there's a secondary cancer reduction with protons. Also, the combined approach using, let's say, chemotherapy and biological therapies with proton therapy makes the tissue more sensitive, and the need to spare that tissue more is even more important. Also, there's looking at reirradiation. So patients that have received treatment and we need to spare the tissue that's already been irradiated in their second course of treatment. And then also, I think both Denmark and Sweden are looking at using comparative treatment planning to guide which patients should get proton therapy. Some of the other ones are looking at ALARA, which is as low as reasonably achievable. And this is looking at how low can we reduce the dose, but it only means something if you can reduce the morbidity and improve the patient's outcomes. Also, there's the model-based approach, which the Netherlands have really focused on and gotten their government to approve, looking at normal tissue complication probabilities and using that with other modeling to determine which patients would be best. And so when you look at those models, though, there's a lot of assumptions that are taken from the photon world and applying it to protons that may not always be transferable. And here are some of the shortcomings. You know, it assumes equality of at least a known relationship between the biological effect of photons and protons, which we know that protons has a higher biological, radiobiological effect than photons. So there's some, that's a controversial matter. There's also, it's defined for certain morbidities, but it does not include the low dose bath, which is one of the main benefits of proton therapy. And then the difference in improvements between one plan and the other can also skew the results. And then also, a lot of these models were not built for model-based selection. They were used for clinical decision support as they were looking at plans. So I'm going to look at, there's been 2 reviews, and they both came out this year on the proton therapy cost effectiveness models. One was out of the UK, that was the first one, and the second one I was a part of, and we just got that accepted and it will be coming out. So I'll just give you highlights of what these 2 studies found. The first one was proton therapy for adult cancer. It found 7 cost utility analysis for protons for head, neck, breast, eye, liver, lung, and prostate. But without the randomized controlled data to inform comparative effectiveness, they had to use one-arm studies or dose response models. And the costing methodologies between all of them varied pretty widely. And the assessment of the model quality highlighted a lack of transparency. So they didn't explain the model parameters, transition probabilities, health state costs, and utilities. So appropriate assessment of uncertainty was often deficient. So with this study, they said estimating the cost of proton therapy is very complex, and it's complex for radiotherapy in general. Definitely, it's a start. We need to build upon what they did and continue to make these models better. We need to continue to get prospective data on protons as well, which will help make these models better. And the normal tissue complication models may not be generalizable over time between protons and photons. So they pointed that out as well. So really, future cost utility analysis should be more systematic in their approach and be expansive in their consideration of uncertainties in light of the clinical evidence. In our study, we looked specifically at head and neck, and we used the 24-item checklist from the Consolidated Health Economic Evaluation Reporting Standards. We also used the Phillips checklist for looking at methodology quality, and the Cooper Evidence Hierarchy Scale was employed for the inputs. At this time, there were only 3 for head and neck, and they used Markov models for the majority of them. The case numbers, the total number of patients, were very low, and some of the structural designs of the models inadequately reflected the natural history of head and neck cancer. The cost inputs were incomplete and referenced historical figures. And then there were issues with some of the clinical considerations as well, not having up-to-date data. So in conclusion, contemporary cost-effectiveness models for head and neck particularly need to incorporate modern estimates for toxicity risk and costs associated with proton delivery to provide a more accurate estimate to improve their clinical applicability. So I apologize. I don't have any water either. The comparative effectiveness of one of the recent publications was done by Baumann. They looked at about 1,500 adults, some of them even getting protons, and they looked at which one had fewer unplanned hospitalizations. And what they found was protons was associated with 2/3 reduction in adverse events associated with unplanned hospitalizations, with no difference in disease-free or overall survival. And proton therapy also had observed toxicity that was favorable with performance status, and they also had the same disease-free and overall survival. So the lower observed toxicity offers an opportunity to explore clinical trials with combining with protons and intensify systemic therapies. We published this one from MD Anderson. We were able to get additional coverage for head and neck, esophageal, breast, lung, prostate in any randomized controlled trial outside of what the payer would include. And we looked at patient-reported outcomes, clinical outcomes, and total cost of care. And so we looked at 1 month pre-treatment, the treatment itself, and 6 months post-treatment. What we found was that after we pared this down to a case-matched cohort, that proton therapy had a net total cost savings, and that percent of radiation therapy to total charges was 77% for protons and 65% for photons, and that the average total charges was actually less after 6 months with protons. And that's because the ancillary costs for internal medicine, pharmacy, lab, ER, and DI were all lower, even though proton therapy was higher upfront. We do want to note that hypofractionated regimens added significant value for protons, and that hypofractionation means using smaller course treatments with higher dose per day. So there have been other value-based publications here, some for the liver cancer showing a 50% overall survival benefit. For esophageal cancer, there are improvements in lymphopenia, but also a reduction in hospitalization stays compared to IMRT and 3D. For head and neck, we've seen a 50% reduction in feeding tube placements. So when we talk about what's important to the patient, work productivity, quality of life, a feeding tube can impact all of those. We also have shown that protons for breast cancer, partial breast irradiation, has good benefits and is also one of the lower cost alternatives because it is hypofractionated. So overall, the relative benefits, even though these are not based on randomized controlled trials, these are the industry experts within the field comparing the relative differences between protons and photons for these different disease sites. ASTRO, which even internationally recognizes their contribution to what the proton space currently indicate the top indications for protons, and group 2 are ones that are suitable for protons with coverage with evidence development. This list, the ones that are in gold, are the ones that they added when they updated their policy in 2015. This, they typically update every 3 years, so I'm assuming that they will be updating this in the coming year. The NCCN, the National Comprehensive Cancer Network, just updated their policies in 2020. And these are all the indications that are that they recommend proton therapy. Now you can see that in some cases for Hodgkin's lymphoma, there's specific, it's only applicable in specific instances where you can spare the nearby organs at risk. So in conclusion, proton therapy is a highly promising technology with the potential to reduce side effects. Further innovation is needed to help develop the evidence and improve affordability. The promise held by protons to improve outcomes for our patient demands that we'll have to engage in proton therapy research and innovation. There have been early attempts at cost-effective models and model-based approach that are promising, but we need to continue that and build upon that and make them stronger. And a path towards proton therapy being a disruptive innovation is clear, but it's up to the industry to decide if that's going to come true or not and become a widely adopted essential component of radiation therapy in the future. Yeah, thank you for your time, and I apologize for the dry throat.
Thank you very much, Matthew, and thanks to all the presenters for all your contributions. Give me 1 second, please. I'm going to share my screen. There we go. Okay. Tako kot že rečeno, najlepša hvala vsem za res odlične predstavitve, za katere pa verjamem, da med vsemi udeleženci vzbujajo dodatno radovednost. Zato bi vas še enkrat vse ponovno pozval k oddaji vprašanj in vaših mnenj na chat. Sedaj pa sledi refleksija ključnih deležnikov, ki jo bo začel gospod Sušelj z ZZZS. Sledil bo pogled Onkološkega inštituta Ljubljana, ki jo bo predstavil profesor Primož Strojan, in na koncu še refleksija onkoloških bolnikov, ki jo bo predstavila gospa Ana Žličar. A najprej začnemo z gospodom Sušljem. Kakšen je bil vaš pogled na perspektivo v tako imenovani value-based modelih, morda še prav posebej na področju onkologije in protonske terapije?
Ja, lepo pozdravljeni ponovno, tudi v tem drugem delu. Dobili smo kar veliko informacij, pravzaprav zelo podrobnih na nekaterih segmentih, ob novostih, ki jih prebiramo, vidimo, slišimo, se mi vedno utrne misel, kako te novosti v slovensko zdravstvo vključujemo. In večkrat sem že opozoril tudi v javnosti, da bi ta naša Slovenija potrebovala neko inštitucijo, nek organ ali agencija, ki bi se sistematično, profesionalno in stalno ukvarjala z ocenjevanjem, vrednotenjem zdravstvenih tehnologij in bi seveda potem imeli nekoliko čistejšo sliko, kaj je že zrelo za uvesti v naše slovensko okolje in kaj ni. Vidim, da profesor Rozman ni več prisoten. Vemo, da se nekaj takega dogaja znotraj zdravstvenega sveta, ampak so to, bom rekel, bolj začasne rešitve ali pa tako skoraj da med vrati, in to seveda ne more biti neka rešitev za državo kot trajna rešitev. Tako da tukaj dejansko vsaka takšna nova prezentacija kaže in kliče potem, da to funkcijo v Sloveniji postavimo kot trajno in profesionalno. Druga zgodba je dejansko vezana na direktno novo tehnologijo, ki jo očitno že nekje uporabljajo, nekje preskušajo, vsaj tako se je dalo razumeti iz zadnjega predavanja profesor Palmerja. Obetajoča tehnologija in pravzaprav sem vesel, da O njej razmišljamo in imamo tudi partnerje, ki so po moji oceni zmožni to pripeljati tudi v naše okolje, tudi na Slovenskem. Vesel bom, če bo dejansko tem industrijskim partnerjem, verjetno v sodelovanju z Onkološkim inštitutom, uspelo to zgodbo o uspehu pripeljati do delujočih naprav in na koncu tudi delujočih storitev za naše paciente. Kot sem razumel iz predstavitve, so še vedno storitve na ta način 2 do 3-krat dražje, se bodo pa verjetno cene le nekoliko postopno približale obstoječim načinom zdravljenja. Ampak, če grem k osnovnemu naslovu današnjega dogodka, dodana vrednost, value-based healthcare, potem seveda ne bomo gledali izključno na strošek, ki ga imamo za posamezno storitvijo ali pa posameznim posegom, ampak dejansko, koliko prenese za naše paciente v celoti oziroma na daljši rok. In tukaj, če razmišljamo, kaj prinaša ta nova zdravstvena tehnologija, koliko manj invazivnega zdravljenja, potem so verjetno tudi izračuni lahko drugačni. Kot plačniki se bomo seveda zavzemali, da ima nov način zdravljenja res učinke za pacienta, bomo pa seveda težili, da bodo tudi takšni načini zdravljenja stroškovno učinkoviti. Sam si ne predstavljam, da bomo imeli v Sloveniji nek veliki pok, pa da bomo od dneva D začeli uporabljati tovrstne metode, ampak razmišljam in tudi delamo že s sodelavci v razvoju korak po koraku, in ko prenavljamo nove obračunske modele, tudi poskušamo na nek način ugotavljati, kakšni so dejansko kakovostni parametri, ki vplivajo in kaj dejansko prenesejo za paciente. Tako da verjetno bomo z neko zveznostjo postopno prišli naprej in tukaj se veselim sodelovanja z partnerji in takih dogodkov, kot je današnji. Hvala lepa.
Najlepša hvala, gospod Sušelj. Profesor Strojan, kakšen pa je pogled Onkološkega inštituta Ljubljana, še posebej z vidika, da je Onkološki inštitut zelo aktiven v aktivnostih, da pripelje protonsko terapijo tudi v Slovenijo?
Dober dan, tudi z moje strani. Ja, kot veste, je Onkološki inštitut centralna onkološka ustanova v Sloveniji. Že od vsega začetka, od ustanovitve, je radioterapija del te inštitucije in seveda logično je, da smo zainteresirani tudi za uvedbo protonske terapije kot najmodernejšega načina, radioterapevtskega načina, ki je ta hip na voljo na trgu. Zdaj, kot nekdo, ki se dolgo časa že ukvarja oziroma ves čas ukvarja z zdravljenjem, znamo na Onkološkem inštitutu prav dobro analizirati na stroške, se pravi realne stroške zdravljenja, tudi z radioterapijo, se pravi uporabo aparature, amortizacijo, stroške kadra in tako naprej, ne. Samo realna vrednost neke terapije je pa mnogo več kot samo stroški, ne. Treba znati oceniti tudi dobrobit te terapije. Ta pa se kaže skozi njeno učinkovitostjo v prvi vrsti, ne, to poenostavljeno rečeno, koliko bolnikov uspemo pozdraviti z nekim načinom zdravljenja. Po drugi strani pa tudi skozi toksičnost te terapije. Namreč toksične dogodke ali pa stranske učinke zdravljenja je treba znati tudi obravnavati, kar tudi stane, po drugi strani pa huda toksičnost, tudi če bolnika pozdravi, tega hromi. V tem smislu, da tudi, ko je pozdravljen, se ne more vključiti v družbo kot aktiven član družbe, ampak je pravzaprav do konca življenja odvisen od pomoči družbe. Tukaj je ta moment toksičnosti je zelo pomemben. In v radioterapiji imamo pravzaprav na nek način en problem. Namreč toksični dogodki v radioterapiji ali pa v radioterapevtskem zdravljenju niso omejeni samo na obdobje za čas zdravljenja ali pa neposredno po njem, ampak se lahko razvijajo tudi leta po koncu zdravljenja, po 5, 10, 15 letih. In v smislu vrednotenja teh dogodkov, se pravi, te plati dobrobiti, če hočete, so se konvencionalna ali pa standardna orodja, kot so randomizirane klinične raziskave, pokazala kot popolnoma neprimerna. Zdaj, ko govorimo pa o protonih, imamo pa pravzaprav težavo celo dvojno. Prva je ta, da ravno zmanjšanje dolgoročne toksičnosti je pravzaprav osnovna indikacija za napotitev na zdravljenje protonov, kar pri 85% teh vseh bolnikov, ki se s protoni zdravijo. Ne povečanje učinkovitosti zdravljenja, ampak zmanjšanje toksičnosti zdravljenja, ki jo znamo zelo na nek način slabo vrednotiti. Drug moment, ki ga je treba pri protonih upoštevati, je pa tudi cena. Zagonski ali pa vstopni strošek je visok ali pa je še zmeraj visok. Veste, v radioterapiji je večina inovacij pravzaprav usmerjena v zmanjševanje toksičnosti. V 70-ih letih smo uvajali linearne pospeševalnike, prej smo imeli samo telekobalt ali pa kobaltne bombe. V koncu 90-ih let intenzitetno modulirano obsevanje. Obe ti noviteti sta bili prvenstveno usmerjene v zmanjševanje toksičnosti. Bili pa sta mnogo, recimo, cenejši, kot je danes morda uvedba protonov. In ti dve noviteti sta vstopili v radioterapijo brez standardne ocene v smislu rezultatov randomiziranih kliničnih študij. Tako da ta negotovost ali pa naše neznanje oceniti vse dimenzije neke terapije ima svoje posledice. Tudi v tem, da povečuje ta razkorak med naprednimi ali pa recimo bogatimi državami in med manj naprednimi državami. Namreč prav na področju protonske terapije je zelo jasno. Na eni strani imamo mrežo protonskih centrov v zahodni Evropi. Ta hip jih je 35 v 12 državah z preko 80 terapevtskimi sobami, kar je ogromen pravzaprav. Po drugi strani pa pod črto Pavija, Trento, Wiener Neustadt pa Praga ni pa prav nobenega takega centra, seveda vključno s Slovenijo. Tako da tovrstne dogodki ali pa predavanja pa diskusije, kakršno imamo danes, močno pozdravljam. In kot predstavnik Onkološkega inštituta sem blazno vesel, da smo del tega dogodka. Namreč skozi te tovrstne prireditve oziroma diskusije naj bi prišli do nekih razmišljanj, ki naj bi bile pomoč ne samo stroki, ampak tudi zdravstveni blagajni, pa ministrstvu, pa pravzaprav državi, ko se odloča o novih terapijah, uvajanju novih tehnologij. Namreč samo napredno razumevanje vrednosti novih terapij pa novih tehnologij za bolnike bo očitno omogočilo hitrejšo uvedbo teh tehnologij, kar pa nikakor ni zanemarljivo. Namreč še posebej, če pomenijo pomembno dobrobit za velik del onkoloških bolnikov. In če govorimo o protonski terapiji, to pomeni pravzaprav 10 do 20% vseh bolnikov napotenih, 10 do 20% vseh bolnikov napotenih na obsevanje. Torej, okvirno vsaj 500 bolnikov na leto v Sloveniji naj bi imelo profit ali pa dobrobit od tovrstne terapije, kar pa niti približno ni zanemarljivo. Hvala lepa.
Najlepša hvala, profesor Strojan. Gospa Žličar, najlepša hvala, da ste danes z nami in saj predstavljate onkološke bolnike, katerim so najsodobnejši pristopi namenjeni in dvigajo tako možnost ozdravitve, kot tudi dolgoročno višjo kvaliteto življenja in s tem velik učinek na celotno družbo. Tako da bi prosil še vas za vašo refleksijo.
Lep pozdrav vsem. Moram reči, da mi je bilo veliko veselje slediti vsem tem predavanjem, ker vedno je zelo fajn izdelati kaj novega in se kaj novega tudi naučiti. Rada bi poudarila to, da seveda v društvu onkoloških bolnikov je bolnik tisti, okrog katerega se slučajo vse naše skrbi. In sicer bolnik v času, ko se sooča z boleznijo, ko je v postopku zdravljenja in potem tudi rehabilitacije. Zato tudi zelo dobro poznamo vse težave, ki jih bolniki imajo zaradi sicer dobrega zdravljenja, pa vseh stranskih učinkov, ki jih potem in vplivov na zdravje, na njihovo zdravje, ta zdravljenja pomenijo. Absolutno podpiramo vedno najsodobnejše, najnaprednejša zdravljenja, ki jih pozna razviti svet, ker tudi Slovenija je del tega razvitega sveta in vedno smo zelo veseli, kadar Sloveniji uspe slediti ali biti včasih tudi pred drugimi strokovnjaki. Kar zadeva uvedbo protonske terapije, zelo dobro se zavedamo, kako je treba biti pozoren tudi na vse potrebne vire, ki jih kakršnakoli terapija, konec koncev v zdravstvu zahteva. Moram pa reči, da me izjemno veseli in da je zelo opogumljajoče to, da ta problem poskušajo z vseh zornih kotov osvetliti tako strokovnjaki z medicinskega, kot tudi ekonomskega področja, kar pomeni, da gotovo se ne bo zgodilo, da bi bili samo zdravstveni ali pa, če hočete, medicinski pogledi na to edini merodajni, ampak da se poišče način, kako to z razpoložljivimi sredstvi se tudi da narediti. Zato jaz to odločanje o ali da in kako uvesti protonsko terapijo vidim tudi kot neko priložnost, da se preveri value-based healthcare na tem primeru in da hkrati je to lahko tudi izziv ali pa pobuda, da se preveri tudi sistem financiranja storitev. In mislim, da bi bilo škoda se zadovoljiti samo s tem današnjim srečanjem, ampak da velja vse sile usmeriti v to, da morda na tem projektu se zelo lepo lahko izkristalizira, kako naprej. Mene je zelo razveselilo uvodni nastop gospoda Sušlja, ki je povedal, da so v svoje strateške dokumente umestili tudi področje urejanja financiranja, zavedajoč se dragih terapij, bodisi da se nanašajo na zdravila ali pa na postopke zdravljenja. To mi da, rada bi verjela v to, da seveda je tudi pri njih interes in da je v središču tega dogajanja tako bolnik kot skrb za javna sredstva. In jaz želim, da se ta zgodba dobro konča zaradi slovenskih bolnikov.
Najlepša hvala vsem za podano refleksijo. In zdaj imamo, pa mislim, da smo sicer že malo čez čas, ampak vseeno bi si vzeli še malo časa za vprašanja. Tako da nekaj ste jih napisali in bi kar prvo prebral, samo sekundo. Pa bomo vprašali. Evo, takole. Se pravi, do you have information who is responsible for establishing BPT criteria and who is following the effectiveness of the criteria? Jan is asking, and I believe the question is for Katja Grašič. So Katja, if you could please.
Torej, NHS England ima trenutno ta program BPT, v katerem je trenutno, mislim, da več kot 80 različnih teh skem. Ta za kolke je samo ena izmed teh. Torej, odgovornost za to ima organizacija, reče se NHS England, ampak vsaka od teh skem pa ima svojega voditelja, recimo. Skeme so za različne stvari, nekatere so tudi za naprimer,
sorry, Katja, maybe I would recommend if you would answer in English. I'm not sure Jan is Slovenian.
Hi, this is Jan speaking. Jan is Slovenian, ja, v slovenščini je čisto ok, če mi odgovori. Pa mogoče bi tukaj nadaljeval še vprašanje za odločevalce pa deležnike v našem zdravstvu, ki jih je tukaj kar nekaj prisotnih na tem predavanju, kako vidijo, kdo bi bil v naši shemi zdravstveni odgovoren za postavljanje takih kriterijev. Se pravi, če je to v Angliji NHS, ne, kako to, a je to možno prevesti na slovenski model?
Mislim, da predvsem v Angliji se stvari dogajajo po različnih lokalnih skupinah. Torej, naprimer, ta za kolke je organizacija, ki se ukvarja z kvaliteto zdravja za bolnike s kolki in preko njih potem pride to v veliki meri potem do policymakerjev. Torej, mislim, da tudi večinoma vidimo, da je najboljše stvari, torej tisti programi, ki so najbolj uspešni, so bottoms up, torej pridejo od zdravnikov do odločevalcev. Kot sem rekla, nekih programov je veliko za zelo različne skupine.
Okay. Hvala.
Tukaj, če smem, mogoče samo jaz na hitro vskočiti v debato. V Sloveniji je seveda to vprašanje tudi plačnika in kot je Katja rekla, pa v mojih predstavitvah je bilo tudi to posebej izpostavljeno, ko take kazalnike razvijamo, jih moramo razvijati v bistvu v sodelovanju z bolniki, vsi deležniki skupaj. V Sloveniji recimo imamo že, nekaj izkušenj, ko so se postavljali klinični registri in praviloma, ko se take aktivnosti začnejo, so tudi od spodaj navzgor, pri zdravnikih, potem pa pogosto, kasneje se ugotovi, da določeni kazalniki, ki so zelo relevantni za bolnike, pa tudi potem za tiste, ki poskušajo ocenjevati učinke, tako kot smo se prej pogovarjali, kako oceniš učinke toksičnosti, taki kazalniki potem manjkajo. Tako da je na začetku zelo jasno treba te stvari razmisliti.
Ok. Nadaljujemo z drugim vprašanjem, second question. It's meant for all the contributors. So the question is from Ivona Peric, and she wants to know, what do you see as a biggest challenge for the implementation of value-based healthcare in Slovenia? Is it possible that the value-based healthcare is value-based procurement is introduced through PPI, so that's public procurement of innovation, that is supported by the EU, so the European Union?
In English or in Slovenian?
Well,
morda, ne vem, bom tvegala pa v slovenščini, ker gre za vprašanje, kaj je po recimo naši oceni ovira za Slovenijo. Jaz mislim, da smo nekaj teh ovir že naslovili, ne? In ena od zelo pomembnih stvari, ko opazujemo izdatke za zdravstvo, mi se zelo fokusiramo na tekoče izdatke za zdravstvo. In zdaj tekoči izdatki so bili okrog 4 milijarde evrov lani, a ne? Pogosto pa seveda pozabimo tudi na investicijske izdatke, a ne, in predvsem na to, da ko opazujemo izdatke za zdravstvo, v mojih predstavitvah tega nisem imela časa posebej izpostaviti, ampak ko se o tem pogovarjamo, ne, je treba od celega budžeta najprej denar nameniti za to, da zdravstveni sistem lahko deluje. In če pogledamo malo zgodovino pri nas, a ne, kje se je varčevalo, ravno pri investicijskih izdatkih, ravno pri, ne, mi te operativne stroške organizacij, kot so ZZZS in tako naprej, pogosto gledamo negativno, ampak brez takih investicij, a ne, ki niso medicinske, mi seveda zdravstvenega sistema ne moremo koordinirati, voditi, ne. In to se vidi tudi zdaj, če mene vprašate pri obvladovanju korona krize, a ne, kjer je ogromno vprašanj, ne medicinskih, ampak so vprašanja organizacijska, a ne, in je zato tudi treba imeti ustrezne resurse, da te stvari lahko podprejo, a ne. Mislim, da je bilo tudi v odgovoru komentirano, da morda mi dovolj podatkov še nimamo, ampak da jih imajo v tujini, in tle Slovenija je v prednosti, ker se seveda lahko iz izkušenj v tujini uči, a ne, ampak izkušnje recimo tudi z uvajanjem SPP-jev kažejo, ne, da je potem, tudi če začneš z izkušnjami v tujini, treba potem to prilagoditi slovenskemu sistemu, zato moraš imeti pa resurse in je treba tudi v te resurse aktivno investirati.
Super, najlepša hvala. Želi morda kdo še kaj dodati? Sicer izgleda, da bomo tukaj zaključili. Če imate morda še kakšno vprašanje konkretno za kakšnega od naših gostov danes, jih lahko tudi napišete k nam na mail, pa jih bomo mi probali forwardirati naprej, da boste dobili odgovore. Sicer pa smo dogodek pripeljali nekako do konca, ki pa predstavlja, mislim, da le prvi korak v, verjamem, zelo konstruktivni nadaljnji diskusiji. Jaz se od vas poslavljam, besedo bi pa v tej točki predal Petri za nekaj zaključnih misli, tako da Petra, izvoli.
Okay, hvala lepa. Torej, želeli smo načeti debato, ali je value-based healthcare prava strategija. Pravzaprav gre po svoje za zelo nenavadno besedno zvezo, malo ste opazili, da se celo izogibamo zaenkrat še prevodu. Nekaj jih je, ampak mislim, da se še nismo čisto domačili in odločili, kaj bi bil pravzaprav pravi prevod v slovenščino, in malo je to povezano tudi s tem, ker ne, pravzaprav odraža temeljno poslanstvo zdravstva in je po definiciji edina prava strategija, ne. Je pa veliko vprašanje potem, zakaj pravzaprav tega ne izkoristimo v zadostni meri, in jaz mislim, da ne gre za information overload, kot včasih mislimo, ampak za filter failure. In imamo dovolj orodij v rokah, da pravzaprav zdaj se odločamo drugače, ne. Ta orodja so na voljo in jaz mislim, da je naloga nas vseh, da seveda nekje začnemo, a ne. Z malimi koraki se pride daleč, tako da glede na to, da smo kar precej posegli v vaš čas, bi se vam v tem trenutku zahvalila. Najlepša hvala tudi vsem govorcem, Kati, seveda tudi Josepu in Metu, ki sta osvetlila izzive in priložnosti pri uvajanju protonske terapije, kar je posebej zanimivo tudi glede na ambicije Slovenije pri uvajanju te, ne. Tudi malo, če ste poslušali, ne, sploh v Evropi ne bo šlo samo za vprašanje, kako bomo organizirali nacionalni zdravstveni sistem, kako bo izgledala nacionalna zdravstvena mreža, ampak bodo mreže tudi transnacionalne, in v Sloveniji je tudi to pomembno, ne, da v zdravstvu imamo nekatere centre, nekatera področja, kjer seveda bomo imeli tudi širši doseg. Tako da verjamem, da je današnji dogodek začetek te poti, s partnerji jo bomo nadaljevali, načrtujemo ponovna srečanja in skupne napore, da seveda ustvarimo podlage za to, da bomo takšne premike, o katerih smo govorili danes v zdravstvu, tudi uresničevali. Hvala lepa.
Hvala, naslednje.